Our next talk is titled Quantifying the Charges of Creating and Maintaining Hemodialysis Access in an All-Payer Rate-Controlled Health System, presented by Rebecca Sorber on behalf of the groups at Johns Hopkins, UT San Antonio, and the South Texas VA, as well as the UCLA School of Medicine.
Thank you for allowing me to share our research, quantifying the charges of creating and maintaining hemodialysis access in an all-payer rate-controlled health system. We have no relevant financial disclosures. The number of patients with end-stage renal disease in the United States has steadily increased over the past 30 years, and the number of permanent hemodialysis circuit maintenance procedures has increased 25% since 2010. Despite being a substantial component of healthcare delivery, optimizing the value of permanent dialysis access has proved difficult due to a large and heterogeneous end-stage renal disease population. Recent initiatives by the Centers for Medicare and Medicaid Services to implement episode-based cost measures has generated interest in quantifying robust cost data for all phases of hemodialysis access placement and upkeep. The aims of this study were to quantify the unique charges associated with first-time hemodialysis access placement and maintenance, stratified by access type. This study encompasses a retrospective cohort derived from the Maryland Health Services Cost Review Commission Administrative Claims Database and included all patients undergoing first-time hemodialysis access placement between 2012 and 2020. We excluded patients with prior permanent access placement, as well as those who experienced mortality, were lost to follow-up, or received a renal transplant within 3 months of their initial procedure. We accrued placement and maintenance data from only the outpatient claims, utilizing CPT codes. Maintenance in this study was defined as all dialysis-related imaging procedures and reinterventions, both surgical and endovascular. In order to properly contextualize these results, it's important to note that Maryland implements a unique all-payer rate-setting model of healthcare delivery, in which rates for procedures are predetermined regardless of whether the payer is Medicare or a third party. This means charges rendered and the eventual cost to the payer are equivalent in this system. Overall, we captured 12,716 procedures, of which 8,818 were fistulas and 3,898 were grafts. Patients undergoing graft placement were older, with 55% of them over the age of 65 versus 50% of fistula patients. Patients undergoing graft placement were also more likely to be Black, Medicare beneficiaries, and to have end-stage renal disease rather than chronic kidney disease when compared with patients receiving fistulas. Overall, the average total charges associated with new hemodialysis access in the first year were $10,658. When broken down by access type, arteriovenous grafts generated charges over $4,000 more than fistulas in the first year on average. This cost difference was present both in the charges associated with placement as well as maintenance charges. These differences in maintenance charges persisted over the subsequent 3 years. Kaplan-Meier analysis of reinterventions demonstrated that there is no difference in freedom from reintervention between the two types of access at any point in the years following initial placement. However, a closer look at reinterventions demonstrates that the mean number of reinterventions required by grafts is consistently higher when compared to fistulas, and, consequently, the charges associated with reinterventions are also higher for grafts compared to fistulas in the year of placement and over the subsequent 3 years. On multivariable analysis, arteriovenous fistula placement was associated with a reduction of $3,557 in mean lifetime charges when compared with arteriovenous graft placement. When examining only patients 80 and older, this difference in charges remained significant. Arteriovenous fistula placement was associated with a reduction in charges of $2,373 when compared with arteriovenous graft placement. In conclusion, the average per episode charge for placement and maintenance of permanent first-time hemodialysis access was $10,658 in the first year, a cost which varied significantly by access type. Arteriovenous fistulas required fewer interventions and were associated with lower charges at placement and in the first 3 years of maintenance when compared with arteriovenous grafts. The use of arteriovenous fistulas for hemodialysis access represents an opportunity for healthcare savings in select populations. Thank you.
Congratulations, Dr. Sorber, and thank you for a wonderful presentation. I think this highlights really how you're utilizing such a well-planned system, meaning you have the payer data set from Maryland that really seems to lend itself to answering this question about cost for something that's so well what am I trying to say, leveled across the playing field, right? I was curious going into this, if you wouldn't mind just clarifying for us the terminology of cost versus charges. You use those, it appears, interchangeably throughout the talk, and I know that those can be varied and interpreted in various ways. Would you mind just elaborating on if we're just talking about charges or other terms of costs here as well?
So in our study, so charge and cost should be equivalent in the system. So cost is generally what the payer actually pays, and charge is actually what is rendered to the payer, and then is usually negotiated between the hospital and the payer to come to the eventual charge, the cost that's actually paid by the payer. In this system, it's nice because those two things are equivalent. In other systems, the cost that is actually rendered to, let's say, a Medicare patient and a cost that is actually rendered to a private insurance patient may be different, but in this system, they're the same. So I may have used them interchangeably without meaning to, because they are equivalent in ours, but you're quite correct. In other systems, there is a wide amount of variation, and Maryland has really worked to minimize that by utilizing this.
Again, a nice highlight for why this system lends itself to studying this point, to actually get rid of the confusion between cost and charge that is so ubiquitous in these studies. That's great. And so just to make sure that I understand correctly, you're saying that the cost of a graft per episode of reintervention as well as per episode of placement is more expensive, or is that per episode over 1 year increments?
It's per episode over 1 year increments. When you break it down by placement, when you break it down by cumulative reinterventions, it's higher for grafts in terms of placement and for reinterventions. But in terms of individual episodes of reinterventions, that's not something that we looked at in terms of individual encounters, rather cumulative charges or cost over a year.
Gotcha. And so now if I were a payer system looking at this, I would come back and say, you should always put in a fistula. It's more expensive to put in grafts. How can we use this data to perhaps level the playing field of cost in such a system? What would be the impact of this work in that sense?
Yeah, I think it would be short-sighted to say that every single patient needs to get a fistula based on this, although I think probably some payers might look at this and push for that just based on this. What is not visible in this, because it had to be a 4-minute presentation, was that you do lose those fistulas that don't mature. If you compare the curves between what number of patients still have functioning access, in the first year and a half or so, you see a decrease in the amount of fistulas, and that's due to those fistulas that don't mature. However, that subgroup analysis that we did of the older patients, I think really highlights that if you have a patient that has amenable anatomy, it's really worth it to give it a shot. The other literature that's out there would emphasize that if your patient has at least 2 years of life left, fistulas are really a cost-effective option. And then additionally, there's some great work by Ben Brook out of Utah that looks at the cost of reinterventions, looking at a cost-benefit analysis, and they really say that you should try to salvage it at least a couple of times before the cost of replacing new access becomes worth it.
That's very helpful. That goes along the question that Matt Corrier posed here about the implications of a non-maturing fistula. I guess the question is, do you have a sense on cost per patient at this level rather than per fistula in the system? Meaning, is the cost cheaper perhaps for somebody that is getting a graft de novo versus somebody who has a non-maturing fistula and then needs a graft later on?
That is possible. We didn't flesh that out. That would be a really interesting thing to look at. If you look at more distinctly at the table that has the number of reinterventions, it shows that in the first year, there was like a lot higher number of reinterventions versus the subsequent years. And a lot of that represents those fistulas and grafts that need a lot of interventions and eventually get abandoned and fall off. So I think that's not something that we specifically looked at, but I certainly think that you're correct. If you put a fistula in a patient that really doesn't have a chance of maturing, it certainly is going to be quite expensive, on the order of, I don't know, in terms of, if you look at the reintervention costs, about 2/3 of it is endovascular, and a third of it is surgical. So those endovascular interventions really add up. So it is something you really need to consider if you're doing something in a marginal patient.
Yeah. Question by Sharon King. Was follow-up for fistulas the same as grafts? And if an intervention was required, were they performed by a singular service or divided between vascular and IR based on fistula versus graft?
So we looked at this in answer to the second question. We looked at this based only on CPT codes. So we didn't look at it based on specialty. You could look at that. There is some literature out there that would say that utilizing interventional radiology would decrease your costs because you don't use as much regulated space and as much OR time, and it's a more cost-effective thing for the patient. However, that wasn't something that we looked at in here, but it is an excellent question. In regards to your question about follow-up, our follow-up for the two groups was slightly longer for grafts. The mean follow-up for both groups was about 2 years. So I would look at that data beyond 2 years with a little bit of more trepidation, but it was excellent for the first 2 years.
Good. James Yanuzzi asks or says, great work and very important topic. We generally take a fistula first approach, and grafts are reserved for those that are not fistula candidates or have failed a fistula. Did you look at whether AV graft patients had prior access attempts?
We actually excluded anybody who had prior access. So this was all first-time access patients. We thought that it would muddy the waters too much to put in people that had redo access because that's such a different population of patients. So every single patient in here is first-time fistula or first-time graft.
And then Dr. Corrier also asked if you looked at catheter-free days and if there was any association with cost.
We did not look at catheter-free days. That would be interesting in terms of catheter-free days and in terms of hospitalizations for catheter-associated infections. I think those would both be very interesting questions that would support this data. However, I will say that we tried to incorporate inpatient data into this analysis, and we found it to be very, very messy. And it added a lot of just error to the data. So that's why we just chose to focus only on outpatient data. In order to include what you're asking, it would be inpatient data. So in answer to your question, that's a great question, and it's probably something that we should look at in the future, but it's not included in this analysis, unfortunately.
Great. Well, thank you. Those are all the questions. Again, very nice presentation on a very important topic.
Thank you very much.